critical incident stress management team was our hospital social worker who just recently retired, Jan Davies. A lot of you probably know Jan. She was a social worker back in 1990, and we didn't have any chaplains at the hospital. Warren Hebert was the county chaplain, and he ended up doing a lot of the spiritual care at the hospital. And Jan was a social worker, and so she ended up, doing a lot of the work that you guys do now. And so from the beginning of, well, all around the nation, but specifically here in Montana, chaplains have played a real crucial role on the CISM teams and in the county, on the county teams, and just on the hospital teams. So Tim, I know you, we talked a little bit about, do the rest of you know anything about critical incident stress management? Or did I miss anybody who was in my class? And anybody? I got 35 minutes. I need somebody to answer my question. Does anybody know nothing about it? You know nothing. Good. Thank you. So critical incident stress management is a set of interventions that you can do sort of before, during, or after a critical event. But it's basically peer support. So, or it's spiritual care support. So it all fits under what you do, fits under the realm of critical incident stress management. The debriefings that Tim talked about they're sort of like the last thing that we do. Let me just think here. Do I want to back up? The main thing that we do, I'm going to start first with the main thing that we do is peer support. So if I'm teaching a class of cops, firefighters, EMTs, emergency room people, or emergency department people, ED, in my world, ED means something else than for you guys, but it's the truth. But I have a hard time calling it not emergency room. So anyway, but we get, the first responder professionals after the really serious events. My job is I train in people how to do peer support. And so this class that I teach that a lot of you have gone through is basically the first 2/3 or half of the day is about the different kinds of stress, what to look for in yourself and your coworkers, what does stress look like, what does cumulative stress look like, what does critical incident stress look like, and then ways to take care of yourselves. Because when you do peer support or spiritual care, it's not ongoing therapy. So it's kind of a get in there in an intense or right after an intense situation, see how people are doing, let them talk, and then offer them some resources and reminders of how they can take care of themselves better, in the hours, days, and weeks to follow. So the one-on-one peer support or spiritual care support that we trained you to do, which is, I'm sure you already know how to do it. You're all chaplains or pastors anyway, so you probably already know most of this stuff. It's just a little tweak on it when there's a critical event. There's different, it manifests in slightly different ways than just regular, medical sorts of situations. So the one-on-one peer support is one of the things that we do. We do diffusings, which I know that our hospital has started doing quite a bit, or I believe they were doing them more when COVID started. I had a meeting with our behavioral health people at the hospital. It was probably March 13th. I think that was the date, March 13th or 15th of 2020. It was right when things were starting to shut down. It was either the week right before everything shut down or the week of that everything shut down. And they said, at that point, they didn't know how many, we were expecting, we didn't know how many people to expect. And so they were trying to gear up to get ahead of it a little bit so that they could be prepared to take care of their nurses and doctors and other folks who work in the hospital. So we came up with a plan to do potentially diffusings, what we call diffusing. So a diffusing is something where you just let people talk, like at the end of a shift before they go home, or right after, say, a trauma call, to talk about what they've just been through, and let them tell a little bit of the story of the event, and then you send them out of there reminding them of take care of yourself afterwards, watch how much you drink, and drink a lot of water to wash out the stress chemicals out of your body, and eat right, spend some time with your kids or your dog, or doing things you love with people you love. Don't spend too much time alone unless that's really what you need. And just kind of, most people know how to take care of themselves pretty well, but our job sometimes is just to remind them of what they already know. And so we set up this plan with the hospital, how to do diffusings at the end of shifts or at the end of particular calls. And so diffusings are one of the things, if you take the class, that you'll learn how to do. And they work really well. We also set up for the COVID planning, who's going to do the one-on-one stuff, touch base with people, how do you show them appreciation, things like that. So I was thinking about this, Tim, after we spoke earlier. I could send you a handout of what we used. It's probably we're behind the curve by about 2 years now, but it could be, you could still use it in regular hospital situations, not just the COVID stuff. One of the things you learn in the class, that in the training, how many of you have your hospital's employee assistance program phone number in your phone so you can give it to those nurses and doctors? Good, Grant. Good, Tim. Yay. Look at you all. So that's one of the important things, is to know what resources are out there to refer people to, because in spiritual care, this again is the danger, is getting too involved with too many people and trying to do too much, trying to do spiritual care with somebody who needs therapy. And so for us in mental health and chaplaincy, first responders, nurses, medical doctors, all those, our biggest problem is saying yes to too many people too much of the time, and not saying no, because we're not going to be good for anybody if we don't take care of ourselves and fill our own tanks. So that's one of the things we talk about in the class. We talk about cumulative stress, because my guess is that some of the things that you all deal with, I know you're dealing with families that come into the hospitals, but I suspect you're dealing with coworkers and employees too, who are struggling. And a lot of those people are going to be dealing with is cumulative stress of the job. Management, shift work, hours, coworker gossip or coworker bullying. I mean, are you guys seeing that? I hear about that at our local place. So how do you help people through ongoing things? So it's not just the critical events, it's dealing with ongoing things, or burnout in people who are, tired, worn out, haven't had a vacation in a long time. And coming off COVID, I'm imagining you're seeing a lot of that kind of stuff. The debriefing then, the critical incident stress debriefing that we teach in the class is a 7-step process. It's for really serious events that are what we call a higher than average yuck factor. Is usually going to be something in your emergency department. A lot of times we have intervened, or we've been asked to come in, our critical incident team comes in when there's a fetal demises, or a maternal demise, things that are just not in the typical repertoire of what they see anywhere. So we can, come in and follow up. It's a 7-step process where we have people talk. We have them talk about, first part's an introduction. Second part is tell the facts, tell the story of your role in the event. And then we have them talk about their thoughts. We go around in this, circle or chronologically, whoever was there first to whoever was there at the end. And what'd you do? Then what'd you think? And then we have them go through what is the worst part for you. What was the worst part for you from this call, this event? And then they talk about that. And that's often where you hear what's really sticking with them. And that's what you're looking for too, is what are the things that are sticking? Is it something that they saw or heard or smelled or touched, things like that, or some aspect of the call that was, or the event that was really unusual or rare. Those are the things that make something critical or traumatic. And then we ask, have you noticed any changes in yourself in the few days since this? So we don't do the critical incident debriefings right away. Anywhere from 2 to 10 days is fine, and once in a while we've done them later than that, and it works whenever you do them. So then we ask, what have you noticed in yourself? Have you noticed any changes behaviorally, cognitively, in your thinking processes, or emotionally, more tearful or angry or cranky or things like that? And people talk if they have anything to say. And then we do a little bit of teaching. And the teaching part is, part of it is we normalize everything we've heard. And I don't care if somebody says, have you ever heard this before? Sometimes people say, have you ever heard this before? And I'm like, well, no, but it sounds like it would be normal given what you went through. So you try to normalize them as much as possible, because part of what can make it an event tough for people is they don't, they're behaving differently than they typically would. They're responding differently than they ever have before, and they think something's wrong with them. And so our job is to help them get through that, but recognize that this is just one of the ways your body, your brain is kicking this thing around and trying to get it, moving down the road. So we talk about things to look for, ways to take care of yourselves, and we just basically hit the highlights of self-care. One of the things I always tell people, some of you have been in the classes where I say, if you're talking, you're healing, and if you're crying, you're healing. So if you can, anytime you're getting those feelings out, you're healing, you're talking. Anytime you're talking, you're healing. And so that's the most important thing to do, is talk to people you trust and love. People who are confidential, obviously. I have this husband, I'm like, I got to tell you something about a client, but you can't tell anybody. He's like, well, you're not going to tell me their name, and I won't, who would I tell anyway? That's his. So I talk to my husband a lot about just, like, oh my God, I heard this thing, and it's sticking with me a little bit. So have the person you love. We talk a lot about drinking water. If you're crying, you're getting the stress chemicals out. If you're exercising, you're sweating the stress chemicals out. If you're drinking a lot of water, you're getting the stress chemicals out that way. And so just real basic stuff, reminding people to watch the alcohol intake, keep it minimal, and for the next, X number of hours, 36, 48 hours, 72 hours, because alcohol interferes with REM sleep. REM sleep helps us heal. And, I always liken an emotional trauma to a physical trauma. If you've I don't know, if you were running and you fell down, you got a scraped knee and a bruised leg, you've got a trauma to your leg. And so how do you take care of the emotional injury, much the way you have to pay more attention to it in the days after, until it's, and as it's healing up. So just, we hit the highlights of self-care and ways to take care of yourselves. And then the end of the debriefing, the 7th stage, is what we call the reentry stage. It's just are there any questions? Are there any leftover things people didn't say, forgot to say, thought about? And so by the time we go through that, depending on the number of people in the room, it'll take half hour to 2.5 hours, depending, and how much people talk, how little people talk, things like that. That's not the end of healing, it's the beginning of healing, because you've started them on that process of discussion of an event. So they've got a little bit of practice letting out what their part was and how it's showing up in them. And so that's the debriefings are the things that we do the least frequently of all the interventions in CISM, but they're also they're usually pretty needed when we do them. And so those are the kinds of things you learn when you take the class. So what I wanted you guys to have the opportunity to do is ask me questions, or ask any of the people who've done the class questions. Jenny, you're on the Flathead Valley team, aren't you? And Wendy, I know you're on the National Park Service team, aren't you? And you're on our Gallatin County team if you're ever back in the world here. So what questions might some of you have?
I have one, Carol. So we've coming to the end of COVID. Mm-hmm. This is a 2-part question in case other people get curious and take up my time. The first thing is, there's something that's happened at the end of COVID, a year and a half, 2 years, whatever that is, that the stress starts to show up when the stress starts to go away. Uh-huh. So COVID is kind of in decline, and so now people are free to breathe. And like, how do you recognize some of those traits and know that it's time for whichever one of these would be appropriate for that? The second question is like, what's the role of the chaplain when he or she is affected by the distress? So yeah, I give that to you.
Oh, thanks. I'm going to answer your second question first. At the beginning of this thing, this meeting, you talked about your friend who died. You've got, I don't know, 10 people on here, some of whom will call you and check in on you after this meeting and say, tell me about your friend. So when you're affected, it's perfectly okay. At least, I don't know, in my world, it's okay when a client comes to me and says, this is really bothering me, and I'll say, it's really bothering me too. So sharing it, don't try to hide, don't try to be stronger than, because boy, that's going to backfire on you and blow up at some point. Mm-hmm. So sharing what's your role when you're affected. If you're really affected, let somebody else do some of that work for a little while. For now, take the time you need, a day, a week, whatever, to kind of get yourself together, to relax, renew, renovate, rejuvenate. And I forgot your first question.
So like the long-term effects of COVID and when it starts to show up, and when is a good time to do a debrief or whichever you would do here?
We talked about that with our hospital behavioral health group, and Wendy, you were there that day too. Debriefings probably all in all work better for single critical events, but like with COVID, what you could do is you could get units together. So crews of people, I wouldn't go bigger than 8 or 10 in a group, but people who mostly work together most of the last 2 years. And what you could do is you could say, give them a week's heads up and say, I want you to think about what were the patients or the days that stuck with you the most in the last 2 years? What is the thing you can't let go of, or things? What are the thing or things you can't let go of? And then bring those. We're going to sit down and we're going to talk about those things and what made them last for you and what struck you about this. You know, a lot of your medical people will have held people's hands when they died, have been in the room and held the phones for their families to talk to them. And, you know, some of those things will have stuck, or maybe they won't even remember names or situations, but they'll remember that they did that. And I guess that's, so sitting down in small groups that are pretty cohesive already would be, you modify the debriefing process. And you just say, you know, what are some of the stories that you worked with, or what's the thing or things that stuck with you the most? And just give them that opportunity to open up and talk about it. And what stuck with you? You know, what was the worst part over the months, or is there anything that's still sticking with you now? Is there anybody you're still grieving for? Those kinds of questions would be your prompts for it wouldn't be exactly a debriefing. It would be just sort of like a follow-up end of COVID sort of group, sort of thing like that. I don't know what you'd call it. Yeah. Does that answer your question, Tim?
To a point. I guess the thing that it's like, I think I missed, and I actually had the nursing manager on the medical floors ask me to do a debrief with staff. And I'm like, what have you seen? What are you seeing that makes you think now's the time? And she was talking about staff who were taking a lot of time off, some that were retiring or quitting for whatever reason. The way that they're getting along with each other or not, you know, those kind of things. It's like, so what are you looking for? What are the indicators?
Those are what you're looking for. Those are exactly what you're looking for. So your nurse manager who came to you is astute.
Yeah.
Those are exactly the things you're looking for. People who aren't getting along, people who are quitting, people who are taking more than usual days off, calling in sick more often. You just went through the list. Those are, so you're looking for changes in a person's typical behavior.
Yeah, yeah.
And you just also brought up another thing that triggers me to think, invite those people who've quit to come in and speak.
Yeah.
Don't let them go. Say, come, we're inviting you to this. You can't force them, obviously, but we'd like to do an end of COVID thing. We realize you've retired, but something you have to say could be really helpful to somebody else here, you know? And chances are it would be really helpful for them too.
Yeah, I like that. Thanks.
So Carol, I have a question, and actually any of you that have incorporated CISM into your facilities, feel free to chime in as well. So there's 3 of us that are trained at St. Pete's. There's Trish, myself, and then one of our BHPs is trained as well. One of the challenges that we've run into in integrating CISM is that following a traumatic event or significant event, there's other protocols that various departments want to do, but they call them debriefings, but it's really a root cause analysis or a post-incident analysis. And then we offer the debriefing, and they're like, well, we already went to a debriefing, so why do we need to have another debriefing? And
well,
a good example of this is last year we had an active shooter situation, and the CISM debriefing was the last thing that they scheduled, like a few days after the event. And by that time, it seemed like people were really just talked out about the facts of the situation, but hadn't, you know, gone deeper into their what they experienced and what they felt. So I don't know if you have any suggestions on how we can.
Well, you want to make sure it's actually very good that they do the critique debriefing type of thing. Soon after, what went right, what went wrong, what could we do better? It's good to get that out of the way ahead of the critical incident debriefing. So you have to call it a stress debriefing. This isn't about operations, it's about the stress of the call. We know that things like this can have lasting effects due to the stress and the nature of that trauma and fear. So we want to give you an opportunity to talk about that. And so, yes, they will have been talking about it for days. Some of them will be talked out, and you can't help that. But the other thing is that some people will not have talked to anybody. And I am always surprised when we do some sort of follow-up after some things. I'm thinking, wow, everybody's going to know what happened, and they don't. So it's more likely not for the people who've talked in every other situation, but for the people who haven't. Kim. So that's my thought.
Thank you. That's really helpful.
Good, Terry.
So I've got my hand up. I don't know if I did that right.
You
Oh, I
did,
see.
actually.
Oh, look
Your
at that.
literal one, and then your,
I saw this one.
yeah.
Yeah, I did this one too. So thanks, Carol. This is really good. I can't remember how long ago I took that training in Missoula. Was that 10 years ago? Probably.
Who the hell knows?
Anyway, what I've found is that the principles of CISM can be, and I know you don't recommend this, but piecemeal applied in many different situations.
Oh, yeah.
So that's really good because it's transferable principles
Mhm.
that can happen in a 2-minute hallway conversation,
Yep.
or in a 3-hour debrief. The other thing I've noticed, a couple comments. So in terms of chaplain self-care, we regularly, our procedure usually is that chaplains participate in debriefs. They don't do
Yeah.
debriefs.
That's true.
So
Yeah.
they're there to debrief themselves with, so in other words, that levels the ground.
Yeah, it does.
And then it may be a chaplain or somebody like me who would do a debrief. Ed is retired now, so we don't have him around, and at St. V's. So it's that's a really crucial part, is that sometimes chaplains thinks, well, we ought to go do this debriefing. And it becomes evident that really what we need to do as chaplains is debrief ourselves and do that with the IDT, not just in the chaplaincy department. And then that builds all kinds of bridges for future possibilities. And then you got to do your boundaries about how much you're going to do. The other thing I want to say is there's other things that we found, like we're working on Schwartz rounds. So that's very much a debrief kind of thing.
What is that? I don't know what that is, Terry.
So yeah, I can talk to you about it later, but
Okay.
it's kind of complicated, but it's really it's a debrief. It's like a case study. It's like for me, it's like CPE. So you're getting doctors and interdisciplinary people together to talk about a case, not for RCA purposes or any other purpose, rather to gather and talk about how did I feel when this dialysis patient decided they didn't want to do any more dialysis.
Wow.
Or how did I feel when this person with abdominal varices was bleeding out and I couldn't give any more blood? What did that feel like to me? So it's engaging clinical people on a emotional spiritual level.
Yeah.
So, and that's a very structured program, and it's proven, it's become very popular. We tried to start it about 5-6 years ago, pre-COVID. We didn't get any traction with med staff in our hospital, but now in COVID, of course, it's easy to run, and we're doing a system thing with at many sites with Schwartz rounds, which is so you have a presentation, you talk about it, give them lunch, and so anyway, there's many other ways too to do this. And the final thing I just say is, if you find what I find most valuable, and that's probably because I got gray hair and I've been around a long time in my setting, but I just did a debrief with a PEDS case where we had a death by neurological criteria and donation, and it was very, very complicated, dysfunctional family system. And anyway, it was very stressful. But the biggest thing I did there was say, thank you so much for what you did. And I was there from ethics, but there was no ethical problem there with how we engaged, but there was lots of communication problems when you have an OPO involved, and also the clinical staff, but to be able to say to each one of them, thank you so much for the good job you did, and for them to hear that from someone who they perceive has some authority.
Mhm.
So, and then to also surface what it was, kind of a mixed debrief. It wasn't a pure debrief. So those words I found too, that in different cultures of hospitals, debrief means a different thing.
Yeah, it does.
So
Yeah.
in a lot of places, when we first started doing those, people would say, I don't want to go because I don't want to get in trouble because my supervisor is going to be there. And they think it's some kind of a criticism thing. So you have to overcome that. And the only way to do that is time and experience, and people
And
talk
if
to
the
each other.
Yeah, and if the supervisor wasn't at the scene or at the call or at the event, they don't
Yeah.
get to come to the debrief, but that's easy for me to say. I'm not,
Yeah.
a subordinate of one of those.
And the
but-
ones that are good. We just had a
Right.
thing in our ED. I don't know if you were in that one, Senator, or not, but it was a trauma call, and the chief of staff of the ED called it immediate. It would be kind of a diffusing more, but immediately at 2 a.m.
Mhm.
And so I called him up as soon as I got in, and I found out about it. I said, thanks for doing that, but he led it, and he cried more than anybody. And that made the whole thing very, very effective, So
Yeah.
but that's a culture change that takes time.
Yeah.
So we get the idea that we can get a linear chronological thing, and we'll get this training, then we'll institute this policy procedure. And then when we first started doing it, all the people that came were the ones that didn't need to come. And the ones that needed to come didn't come.
Right.
So we had to overcome that by just being consistent and reaching out and those kinds of things. But it's a great program, and yeah, very, very helpful.
Yeah.
Well, that brings up a question for me. And when we did some of the discussion after COVID started wearing down the first time, one of the questions that I had was this disparity of on something like that. So you're not necessarily doing a critical incident, except it's a cumulative thing. But do you do something different for management versus their underlings? How do you separate them? Like what Hollister was talking about in that event that happened in the ED, ER, whatever. That makes sense that the lead would be there and led it, and he certainly modeled it too. How do you determine that, or what do you suggest in that?
Well, a lot of times what we see is there's mistrust of being able to be very open if your supervisor's in the room. Your supervisor might criticize you, might judge you, you don't want to show weakness, you don't want to show like I was afraid, you don't want to say that kind of stuff.
Evaluate.
So a lot of times it's about what's the relationship. If the supervisor's hands deep in blood right along with the nurses and doctors there, then that person should certainly be in the room. But if they were outside, if they were doing other things, so there's that is one thing. But then management, I mean, geez, I wouldn't have wanted to have been a hospital administrator during this whole thing. Everybody's yelling at you and armchair quarterbacking and, so reaching out to the top people and saying, hey, let's just sit down and talk a little bit. And then you get some mid-management people. And then maybe you go to the people who are paying the bills and making paychecks and saying, how have you guys been through this? How have you guys been through this whole mess? So there are lots of things you could do post-COVID to reach out. And I don't think there's I don't think we got a timeline on this thing. It's, you're not behind the curve if you start doing it this month. Mm-hmm. But yeah, like, your hospital administrators and, just kind of decide what groups go together. Or maybe you just do a download of information and say, here's some things that some people feel after events like this. We've had 2 years of this. Everybody's probably feeling drained and exposed and exhausted and all that, just do a lot of empathy stuff. And here's ways to take care of yourselves. And so you can give, if you have large groups, you could just give information. And that's one thing. And Tim, you said something else that I want to address. You said now we're seeing a lot of problems. Now, you didn't say it that way, but we're seeing things show up now when COVID is over. Why are we seeing it now? When I was in college, I'd get sick every Christmas and every spring break.
Yeah.
I don't have to be on anymore. I don't have to be healthy. So our systems know we've been going, and we had to keep our immune system strong as they could be, and ignore if we're sick or do whatever. And now when I don't have to fight, I can get sick.
Yeah.
And I bet that that's a lot of what you're seeing there is I don't need to put up with this anymore or something.
Yeah.
And it's also, I think too, on top of that, Carol, is cumulative stress. So this debrief I just did in this pediatrics case, I realized that they're not used to DCDs or death by neurological criteria in pediatrics, but also they had been through this whole COVID thing. So then they're raw,
Yeah.
or they're and so that the emotionally, and we didn't address all that, but I think that's a good thing. And I think my experience, I would say, with administration is until you have somebody who's a peer in the administrative team, I don't understand how the military works, Tim, but until there's somebody in administration who knows the value of a debrief and of being honest, it's hard to convince for a chaplain to convince vice presidents and CEOs and CNOs that they need to debrief. They're like, no, we got it together. That's part of their role.
Exactly.
That's why they burn out. But anyway, but when you get somebody that's an advocate for this kind of thing, in our case, it was a CMO, and who realized, and then they're asking for help, and they're not thinking about that this person's way down the totem pole. They're thinking this person has something that we need that can help facilitate. But that takes time and relationship. I think that's the key thing with all of this is relationship. Yeah.
Well, and the other thing I would also encourage is if you guys are dealing with a family of a critical situation, or the family when there's been a death, don't do the debriefing yourself. Be part of it with your nurses and your doctors and your other people. Don't try to be the hero and do two roles, because they'll know you had to be hurt like we were too, or hit. Now, maybe not hurt, but hit, so.
I'm going to have to shut it down. We have decided, by the way, and we've decided that it's always better to leave you wanting more than to keep it going and people start dropping out. Okay. So that's part of the reasoning. If you want to get on me about that, you're welcome to do that. I'm always open to hear it. But Carol, great job.
Can I make one more suggestion? You all have my email.
Yeah.
If you're not on my email distribution list for upcoming classes, just send me a private email to me alone and say, put me on. And I know that Trisha did that the other day. So we have 3 classes coming up in the state: Glendive, Havre, and Kalispell through the rest of the year. The Highway Patrol is sponsoring them. They're at no charge to participants. They're free for you guys.
There you go.
And so this is the last 3 of 8 that the patrol did. And so I would highly encourage you to get into one of those classes. And then other people have classes sometimes too. So you'll get.
Could you send me that information, Carol? Just email that to me, and then I can get that out to everybody here too. That'd
Yeah,
be great.
I'll put you on my list. I'm sending it
Great.
out today. In fact, I'm sending it out tonight.
Perfect. Perfect.
Yeah.
Okay, guys, thanks for joining. It's always great to see everybody. Hope you're doing well. Remember, we're here, so we support each other. That's what we do. So keep that in mind should the need arise. And we'll talk to you all soon. See ya.